How I found the conference so far is that it's really quite interesting. There's a surprising number of people here, many of whom I already know, which has taken me a bit by surprise. And it's rather nice to catch up with people and see them in person as opposed to just seeing them on a computer screen. So the conference is really very, very interesting and promises a great deal. Have I learned anything new or surprising? I've learned some interesting talk about data science and virtual wards. My interest was sparked by this because I've recently been involved with the British Heart Foundation Data Science Centre. And it's an area that slightly scares me because I was dreadful at maths. Still am dreadful at maths. But it's a big thing in research, and the NHS, the country, is gathering so much data, and I'm not quite certain that they know yet what to do with it all. So I was interested in learning about the virtual wards project locally, because virtual wards are going to become more of a thing. And I was just curious, particularly to know whether what impact virtual wards had on adverse events and also on infections, unexpected infections. And the answer is we're still looking into the data about that. I don't know whether COVID has sped up the introduction of virtual wards. I would imagine it probably has. It was something, an idea that was bubbling away in the background, and because of the pressure of COVID. COVID has changed so much, and we are still learning about COVID. And I reckon we are going to be learning new things about COVID for the next 15 years, at least. COVID has changed society in more ways than we possibly realize at the moment. COVID has changed the way meetings are conducted, the speed at which decisions are made, and it's changed the economy, not necessarily always in a bad way, but it's changed the economy in the sense that people are redistributing money in different ways to what they would have done before COVID. So COVID is going to be a very fascinating thing for years to come. I think it's really very important to be involved in research as a member of the public, partly because of the democratic reasons that it's public money and the public should have a say in how that money is spent, but also because what we do as members of the public improves the quality of research. We see things that academics and clinicians don't see, simply because academics and clinicians live and work in their own bubbles. And we come along, and we don't prick those bubbles, but we bring things into those bubbles that they can't see because their focus is so particular in their own disciplines. Public involvement in research changes and improves research, and the evidence of that is that funders now recognize that we bring so much value into research, they won't give money to researchers unless we have been involved. I've been involved in research since 2012. I was wandering around the foyer of the Norwich Hospital, and I picked up a leaflet that was written by Jacqueline Romero for the PPIRES group, virus. And it said, do you have an opinion about research? And I went, well, actually, yes, I do have an opinion about research. And I became involved in that panel. And then I thought, well, I've got more time on my hands, so I'll see if there's another panel. And I joined the Adam Brooks panel. And then I thought, well, I've still got a lot more time. This is really very interesting. So I signed myself up to the People in Research website. And one thing led to another. And nowadays, researchers come to me for help, and I review for many, many different organizations, trusts and panels, principally for the Health Research Authority, the National Institute for Health Research as an internal and external reviewer, the British Medical Association. I do a lot for the Stroke Association and British Heart Foundation, Heart Research UK. I'm involved in many, many things. I have the great benefit of bringing many perspectives to the research conversation. I am where I am because I had a critical illness in 2003. and in my 40s was made unemployable. So I bring the perspective of having been a critical care patient, also the perspective of having been a patient in need of rehabilitation, which I didn't get a lot of. I bring the perspective of having been a carer, because my wife has had several cancers. She's now on her fourth. And I used to be a staff nurse, so I worked in the NHS for many years. And I bring the perspective of knowing how the NHS works at frontline level. And all these different perspectives make me a valuable commodity. There are many elements about research that I enjoy. I find it all very, very fascinating. Focus groups are good because you have good conversations, you draw many different themes out. But I love nothing better than to be faced with 40 pages of a full application and to be left alone for about 2.5 hours. And I will go through that application line by line, and I'll be looking for contradictions, looking for anomalies, looking for things that aren't explained, things that are not properly referenced. I'm looking for, like any funder, research funders are not looking for reasons to fund research. What they're looking for are reasons not to fund research. And those are the things that I'm looking for when I review a research application. Why would a research funder not fund this application? And if I can illuminate all of those things before it goes to a panel, so much the better, because then they can correct them. And if I'm reviewing on behalf of a funder, I can illuminate those things so they can flag these up to the applicant and say, is there something you want to clarify? But I love all of the research conversation. It's all fascinating, whether it's surgical, social, or medical. It's all very, very fascinating. I find it very rewarding, very, very stimulating, very, very interesting, very absorbing. I perhaps enjoyed it a little bit too much, but it's also very, very fun. There are people who clearly are reticent and anxious about becoming involved as a public reviewer. And to those people, I would say, I can help you. You don't have to have a science background. You don't even have to have an A-level in human biology. All you need to do is to be able to look at a hospital drama, for example, and try and imagine you are that person in that bed, or the relative of the person in that bed. If you've got the capacity to imagine what it's like to be a patient, that's all you need to be a public patient reviewer. Because what the PPI is trying to do is to understand the patient burden and to convey that burden to the academics and clinicians. Because the academics and clinicians see the burdens that of academia and the clinical component. They don't necessarily always see the burdens of the patient experience. And anybody who's got an imagination can understand what it's like to be in a hospital bed. And they're the people we want. We want everybody, we want anybody. And anybody who needs to have a conversation about how to do this, I will happily help them. Yeah, there are courses, the websites that would try to explain what PPI is. The NHR website has got an amazing amount of support for people. But sometimes people just need that conversation. And although I haven't been involved in any of those conversations, they're conversations I would have no problem having. It's difficult for me to think of one particular thing because there are so many of them. Currently, one of the more interesting studies I'm involved in arose and had its genesis some years ago at a poster exhibition here at the UEA. I was introduced to Professor Niall Broomfield, and we were talking about the clinical psychology of the consequences of stroke. And one of the consequences of stroke and brain injury is lability. Emotionalism is also known as, where people laugh and cry inappropriately. And this is an area that he was interested in. And one thing led to another, and we're now at this very moment just beginning a study as to whether sertraline, an SSRI, has a benefit for people who experience this. I've been able to contribute quite a bit to this because it's a condition that's a legacy of my own critical illness. And I was prescribed citalopram and for this very thing, and I found I found it awful, and I came off it. It's easier to live with the inappropriate weeping than it is to live with citalopram. So I was able to sort of contribute quite a bit to this study that's just starting. We are looking to develop a patient lived experience advisory forum. So all these, the trajectory of this particular study, I've been there from the very beginning, and I will be there till the very end. It's nice to see things right from the very beginning, because it all started with a casual conversation over a cup of coffee, and one thing led to another. So yeah, I've been there from the beginning, and I'll be there to the end. One of the things that really, really interests me is that it's a very, very common condition, for it's poorly diagnosed, poorly understood, certainly in primary care. People don't know, people who experience it don't know where to go. People who experience it, it takes people it ambushes people, I don't know, it takes people by surprise. It's not something that is really, that they're really told. You've had a stroke, this may be your experience when you go home. So it's very, very intrusive, and it can make people feel very, very isolated and withdrawn, because it's hard to explain why you suddenly stand in the middle of the